I was advised by a colleague against the use of the term, quite rightly, end-of-life care, which tends to be a sub-characterization. Forgive me, I'm going to divide this into two parts, and in the second part I will be using my notes, so if you find me rumbling and fumbling about, it is because I'm trying to find appropriate quotations. Which reminds me of something that G.K. Chesterton said after a lecture that he gave when he appeared to be rummaging in his pockets and breeches and coat for his notes. And this was remarked upon by a member of the audience, and he replied, "Don't worry, all the important ideas are in my head. And there's very little chance of my losing that." So forgive me if I'm fumbling around. I want to divide this into two parts. First of all, what I might call broadly an objective view in relation to the fundamental principle of medicine, which is founded upon the right to life and the principle of human dignity. Happily, I won't have to go into too much detail about the issues surrounding the principle of double effect, because they have already been dealt with, but I may make a few comments in relation to the provision of hydration and nutrition and the use of terminal sedation in those who are nearing the end of life, which is a particular interest and concern of mine, of course, as a gastroenterologist. I may also make a few comments in relation to the question of consent and also the question of the use of donies of lasting power of attorney. In the second half, I want to talk about what I would regard as the subjective part of this issue, surrounding the fundamental issue of the existential problem that we almost have when we are facing patients who are dying. I'm a gastroenterologist, but I can tell you, as far as I know, I don't have any liver problems or gut problems. And most of us as doctors and nurses and healthcare professionals will be dealing with conditions that we are not likely to suffer from ourselves. But when it comes to the care of those who are approaching the end of their lives, we are dealing with something which not only affects them, but which also and necessarily affects us, because we are all going to die. And therefore, I want to concentrate on the existential reality, the more subjective element, if you like. And then in conclusion, I want to bring those two aspects together in the light of what was said by Viktor Frankl, by Edith Stein, by Pius XII. So they are not completely dissociated things. They are, in fact, part of the same issue. Dealing first with what one might call the objective reality and the morality and the legality and how we should approach those who are dying. I would begin by saying that the whole of medical practice is based upon the fundamentals of the natural moral law. And the core principle is the right to life, which goes hand in glove with the concept of human dignity. And the concept of human dignity has been advanced more by the Church than by any other system of philosophy in the world. And those two aspects, the right to life and the dignity of the human person are completely intertwined. And of course, they have a common origin. The Hippocratic tradition is simple, pre-Christian, pre-Islam, and probably largely uninfluenced by Judaism. It is based upon the natural moral law. It is simple. And one of the things that St. Henry Newman, said in the development of Christian doctrine is that morality must depend upon simple principles. But simple principles are often very difficult. If you have a simple and positive principle, like the right to life, the principle of the dignity of the human person, then a number of other things follow from that. And according to Newman, if the fundamental positive principle is correct, a number of other things will follow from that. And during my professional lifetime, I have noticed how it is possible for simple principles to anticipate, as Newman stated in the development of Christian doctrine, future developments. Conversely, if that simple principle cannot address those future problems and difficulties, it casts doubt on whether or not that fundamental principle is correct. Newman also made the point that it is far more difficult to define a simple, positive principle than it is to define a negative one. And if you look at the Ten Commandments, thou shalt not kill, thou shalt not covet thy neighbor's wife or goods, thou shalt not tell lies. These are negative things. And it is easier to define what you shouldn't do very often than what you should do. But going back to Hippocrates, the Hippocratic Oath is clear. Wheresoever I go, and whosoever house I enter, there will I go for the benefit of the sick, refraining from any wrongdoing. I will give no deadly drug to anyone, nor will I counsel such. I will not give a woman a pessary to induce abortion. Simple statements, but founded on the fundamental principle of the right to life. Wheresoever I go, there I will go for the benefit of the sick. And that benefit of the sick, that purpose of medicine, simply defined, was elucidated further by Luke O'Malley of the Anscombe Centre into 4 components. To save life, where possible. To treat disease. To attend to the relief of symptoms, palliative care. And to restore, so far as possible, the mental, the physical, and the spiritual function of the patient. Those 4 aspects contained within that simple statement. Wheresoever I shall go, I will go for the benefit of the sick. What is the benefit of the sick? Simple statement. It's often said that the prime purpose of medicine is primum non nocere. That came many, many years later. It is a consideration, but it is not the primary consideration of medicine. It is a secondary consideration. We do what we do and hope that it will not be harmful. We do not set about our business with the intention primarily of avoiding harm to patients. So simple principles are simple, but they are also complex and difficult. And it's very difficult to define a simple principle, because as soon as you start defining something, particularly in a committee, then you get dozens of different views. And I'll give you one example of that. As you know, after the Second World War, there were the Nuremberg war trials on three premises. First of all, crimes against peace. Second, crimes against humanity. Third, war crimes. Now, they didn't depend upon any statute law or even international law at the material time. So it was only several years after the war that the United Nations decided to formulate a Charter of Human Rights, which came into existence on the 10th of December, 1948. And it was written after the Nuremberg War trials, very quickly, by a group of international experts in law, in politics, in philosophy. It was chaired by Eleanor Roosevelt, the widow of the president, and it had some great jurists and philosophers such as René Cassin and Professor Humphrey, interested in law. And just to give you some idea of how to formulate a simple principle, the committee decided that the fundamental principle was the right to life. And they said that the right to life exists by virtue of membership of the human family. And if you look at the preamble to the United Nations Declaration, it is still there. So the right to life exists by virtue of membership of the human family. The Maltese delegation and various others said, no, too simple. You must add in, and exists before as well as after birth. And the committee said no. The right to life exists by virtue of membership of the human family. You do not need to say before as well as after birth, because that is known. An unborn child is a member of the human family. So from that fundamental, simple, straightforward, but difficult, and much changed and altered principle, the right to life, a number of things follow. And I'm very grateful for Henry Jackson's views on this. First of all, the right to life is fundamental. That means that it is the basis for the enjoyment of any and all other rights. If you have no right to life, you have no right to get married or free speech or a right of justice. If you do not have the right to life, you have no other rights. It is equal. My right to life is the same as your right to life. It is inherent. In other words, it cannot be conferred by anyone or any society or any parliament or any treaty. It is inherent by virtue of membership of the human family. By the same token, it cannot and must not be denied by anyone, either individuals or professionals or society or parliaments. It is universal. It goes back to the time of Hippocrates. It will extend into the future. It exists throughout the world. It is universal. So from that very simple statement that was the basis of the UN Declaration on Human Rights, and is still the first statement in the preamble, a number of things follow from that. Now, from our point of view as Catholics, of course, that concept of the right to life, because we were all made in Imago Dei, is coincidental or interlinked, intertwined by our concept of human dignity. That too is inherent. That too is derived from our membership of the human family. That is derived from our creation by God. That is universal. That applies to all. That is not something that we acquire or lose during our development or later in life, our senescence. It does not depend upon the individual characteristics, like the right to life does not require individual characteristics, achieving a certain standard of development or of understanding or position or status. No. We all have a right to life. We all have a fundamental human dignity. And those principles are for us the basis of our practice of medicine. Simple principles, often overlooked, but applicable, particularly when we are dealing with people towards the end of life. I won't say very much about the principle of double effect because it is so adequately and eloquently been expressed and demonstrated by Dr. Delaney. But when we are grappling with all of these issues, it does depend upon the fundamental understanding of the basic principles, but also the application of those principles, which we learn through experience in whatever specialties we are in. And it also depends, of course, upon intentionality. What do you intend in those particular circumstances? So I won't say much about the principle of double effect, but I am reminded of a very good lecture that I had with others at Guy's as a medical student in the Catholic Society by Dr. Margaret McKerrow, who was a palliative care consultant in the early days in St. Joseph's Hospice. And after she gave an excellent talk on the principle of double effect and palliative care ethics, somebody asked her, well, what about the use of opiates? What about the use of sedation? Isn't that difficult? Yes. So she said, thank you for that question. It's a very good question. And it is difficult. And then she looked over her glasses and she said, but with just a little bit of knowledge and a little bit of experience, you jolly well know what you intend. And that applies to the whole of medicine, palliative care as much as anything else. And as we learn from experience and not just from lectures, demonstrations, we understand more of the reality of what we are doing. And with that knowledge and experience, we come to a greater understanding of what we actually intend when we do something or not in our clinical practice. The other reason that I'm not going to dwell on the question of double effect in palliative care is because for many years, it's not been the very best example of the use of the principle of double effect. And that came about very early on in the 60s and 70s with increasing knowledge of palliative care and a move away from the use of high-dose intermittent bolus injections of opiates and diazepines and so on, to a much more continuous low-grade use of these, low-dose use of these medications. In other words, to suppress the pain rather than to treat the pain. And what they then discovered very early on, now 40 years ago, is that many of the patients that they thought were dying could go home. Many of those that were seen by palliative care could be managed as outpatients. And another reason why it's perhaps not the best example of the principle of double effect is because they learned that if you adequately control patient symptoms and pain, then overall you are much more likely to prolong life than to shorten it. Now, I would be happy to answer some questions in relation to the Liverpool Care Pathway and the use of terminal sedation, if asked. The principle of the use of ordinary and extraordinary means, of course, is well established and was laid down by Pius XII, and the only possible slight change is from the use of the term ordinary and extraordinary to proportionate and disproportionate by the Congregation of the Faith some years ago. I would also like to talk, however, about the question of hydration. As a gastroenterologist, this is very important for people that have had strokes and people who are towards the end of life. And around about 2002, there was a lot of debate, particularly in America, as to whether or not hydration and nutrition could be withdrawn in those who had, for example, persistent vegetative state or who were in process of dying. And at that time, the Catholic Medical Association said, you should continue. And there was a lot of debate with the Americans about that, whether or not it could be discontinued. And this arose largely as a result, in this country at any rate, of the Bland case, where Tony Bland, a victim of Hillsborough, suffered persistent vegetative state and was dependent upon a nasogastric tube to feed and hydrate him. The law is simple but complicated. In order to have the intention of bringing about somebody's death through murder or manslaughter or assisted suicide, you have to have two aspects. The mens rea, the intention or the guilty mind to bring about death, and the actus reus, the guilty act. All five law lords, in the case of Bland, when it came to the House of Lords, were in total agreement that the intention of withdrawing hydration and nutrition was to bring about, in other words, cause the death of Tony Bland. So the mens rea was there. The question was, Was there an actus reus, a guilty act? And their lordships decided that the answer to that was no. Removing hydration and nutrition, aside the question of pulling out a tube or switching off a ventilator or whatever, was an omission and not an act. So there was no guilty act. This was an omission, a failure to act. And the next question was, is there a duty under these circumstances to continue the hydration and nutrition? To which the answer was no, because according to their lordships, that depended upon the best interests, a new term, best interests. And clearly they said Tony Bland had no best interests because he had no interests at all, because he was unconscious. Now, the Bland case crossed the Rubicon. And if you read part of the judgment of Lord Mustill, it caused him a great deal of uncertainty and worry. And uniquely in a lordship's judgment, he said that ethically this did not make sense. The intention is to kill, but there is no actus reus. And in his judgment, he said, to many, this may seem incongruous, or contradictory, or complicated, or even wrong. And certainly from that point onwards, we took the view, as expressed by one of his lordships, that the Rubicon had been crossed. Point of no return. A new principle, in inverted commas, denying the fundamental right to life. So by 2002, the Catholic Medical Association had decided, I think they had decided long before this, indeed around the time of Bland, that there was normally a positive duty to provide hydration and nutrition as ordinary means of care rather than treatment for patients. Otherwise, patients would die. And there are so many examples now, almost every month, of the Court of Protection stopping treatment and stopping hydration and nutrition. So we were firmly of the view that that was wrong. The Americans were in some doubt. So uniquely, we had made up our mind about what was right before the church. So I'll just read you what John Paul II said in 2004. I should like particularly to underline how the administration of water and food, even when provided by artificial means, always represents a natural means of preserving life, not a medical act. Its use, therefore, should be considered in principle ordinary and proportionate, and as such morally obligatory insofar as and until it is seen to have attained its proper finality, which in the present case consists in providing nourishment to the patient and alleviation of his suffering. Death by starvation or dehydration is in fact the only possible outcome as a result of their withdrawal. In this sense, it ends up becoming, if done knowingly and willingly, true and proper euthanasia by omission. And he later defined euthanasia in Evangelium Vitae as to be found in the intention of the will and in the methods used. And the methods can obviously include withdrawal and not simply an actus reus. I'd just like to mention another change that has occurred over the last 30 or 40 years. It used to be assumed that one could go to relatives and friends of somebody who was unconscious or unable to make up their decisions regarding treatment, and that was perfectly proper and legitimate and ethical, and that has been the case for decades. But with the Mental Capacity Act 2005, and Bland, and the concept of best interests, that was changed. So over time, the patients, relatives, and friends were less often invited, if at all, to make decisions or cooperate with decisions for the care of the patient. And that became incorporated into law with the Mental Capacity Act and with the laws in relation to donors of lasting powers of attorney. So over time, the doctors were less likely to talk to the family unless and until they knew the patient had a donee of lasting power of attorney, which gave the person the legal right to make decisions. So there was a substitution there from the ordinary situation of allowing the family and friends to help make decisions and to determine what the patient wants or would have wanted, to a much more legalistic approach in relation to lasting powers of attorney. So one of the things I would insist that you all do is make sure, in good time, that you have a donee of lasting power of attorney, because they are the ones that have the legal right to make decisions for you. And if you or members of your family do not have them, then I can tell you that it is an enormous problem and a terrible battle, which you may even lose in allowing the continuation of proper treatment, including the provision of hydration and nutrition. I'd now like to turn to the other aspect of all of this, what I would call the subjective assessment. I use that simply as shorthand, in relation to the existential dilemma that we all face when dealing with those who are towards the end of their life. Because what we all must do, and it is not often done, certainly by society in general, but also by individuals, is to consider the actual existential problem of our own mortality, the fact that we are all going to die. So when we are dealing with patients, we are also dealing with a fundamental issue that is also and must necessarily and inevitably affect us all. And however much we help those who are dying, as we must and hope do, dying is a uniquely individual and personal but inevitable process for us all. No two people die in the same way. I cannot experience any other death than my own. I cannot transfer it. I may know a lot about it. I may understand it. But nevertheless, both with respect to patients and ourselves, this is a fundamental issue that we all have to grapple with, and I suspect many of us don't. So that's what I would call the subjective element to this fundamental issue. And going back to Hippocrates and the Hippocratic corpus, one of the aphorisms was simply, remember that the most important instrument in your therapeutic armamentarium is yourself. And I think that is particularly true when we are dealing with people towards the end of life. It is not just a question of what we give them and what we do and our diagnosis and our prognosis and so on. It is also a question, particularly when people are coming towards the end of life, as what do they get from the family and friends, the doctors and nurses around them. What do you offer? And we may think that at the time of Hippocrates, little could be done in medicine. More could be done in obstetrics and surgery, little in medicine. But when we are approaching the end of life, and seeing that in our patients, then we are at a stage where we too can do very little. But the importance of the doctor, the nurse, as a person, and not just as a doctor, becomes all the more important. Because this is an issue that they are dealing with and you are dealing with as well. So, one of the books that I read many years ago, and it is still a bestseller, and you can see it in Smith's, is Viktor Frankl's book on the meaning of life. I've read it many times. Viktor Frankl was a doctor. He trained as a psychiatrist. He was incarcerated in Auschwitz. Edith Stein, who I will also mention, was also incarcerated and martyred in Auschwitz alongside her sister. Viktor Frankl dealt with patients in Auschwitz as a doctor who would die. The mortality rate was horrendous. There was little he could do from a medical standpoint because of their condition, because of the camp, because of the lack of resources. So as a doctor, there was little he could do to help those who were dying. Death would be inevitable. And death would be high on the cards, highly probable for the majority of people in Auschwitz. They had an escape committee. You had to wait. And then, in secrecy, things would be arranged, your clothes, your passport, your maps and compasses, whatever, and you would escape. Viktor Frankl was on that list. He knew that as a doctor, he could do little for his patients. He knew that if he stayed in Auschwitz, he would likely die. And on the day he was to finally meet with the escape committee for his escape, he did a ward round on his patients. He saw them. He talked to them. He dealt with them. He did not tell them that he would never see them again. So he met with the chairman of the escape committee after his ward round. He heard what it would entail, how it was going to be arranged, what he needed to do. He thought about it. And then he turned round and he went back to the hospital. Now, I thought long and hard about what made him change. He was a doctor. He could do nothing medically. He was risking his own life by staying in Auschwitz. His patients would almost all certainly die. So how did he change? And there are a number of quotations that I'd like to say from this, which help to explain his approach to this existential dilemma, not only affecting his patients under desperate circumstances in Auschwitz, but also himself. We who lived in concentration camps can remember the men who walked through the huts comforting others, giving away their last piece of bread. They may have been few in number, but they offer sufficient proof that everything can be taken from a man but one thing, the last of the human freedoms, to choose one's attitude in any given set of circumstances, to choose one's own way. As the inner life of the prisoner tended to become more intense, he also experienced the beauty of art and nature as never before. Under their influence, he sometimes even forgot his own frightful circumstances. And he quotes there, going from Auschwitz to a Bavarian camp, looking up at the sky and seeing the marvel of the mountains, the trees, and the sky. There is freedom that no one can ever take from you. The freedom to choose the person you are going to be in any set of circumstances. He goes into further detail, distinguishing what he calls self-actualization from self-realization. And he talks about self-actualization in the sense, and it's very common, and you've heard about it and seen it a lot, that when faced with the dilemma of death, the individual wanting self-determination, wants to deal with the issue, wants to deal with the death, wants to deal with the drugs, wants to deal with where they're going to be, etc., even in the face of an incurable condition. You want to remain in control. Self-determination, self-actualization. I was discussing about a week ago a colleague in the BMA who is profoundly pro-euthanasia. And my other colleague said, who also knew him, that this was out of a profound fear of his own death. He had not been able to overcome self-actualization, the idea that I'm in control, even in control of death. And in The Search for Meaning, Viktor Frankl contrasts self-actualization with self-transcendence. In other words, you're faced with a problem. You can't control it. It is inevitable. As in death, you then transcend yourself. You move out of yourself. You move beyond yourself. You can see the sky. You can see the beauty of creation. You can understand poetry. And like those prisoners handing out their scraps to fellow inmates, they could see the importance of reaching out to others. And in essence, he says that this self-realization can come through a belief in something beyond self, or it can come through love of another. And of course, from our Christian perspective, those two aspects are intertwined. Our belief in God, our love of God. And going back to what I was saying at the beginning, it is difficult to define a positive, simple principle. But the two fundamental principles of our Christian faith are love of God and love of neighbor. So Frankl was able to distinguish self-actualization from self-realization. And the ability of human beings, even in the face of death, to go beyond themselves, to reach out to others, to reach out to their fundamental beliefs. And there's no doubt that death tests us in our beliefs. And above all, to reach out in love, which in this context, of course, means the love of God. I'd now like to conclude really by quoting from Edith Stein. When I was a student, Edith Stein was very popular. She was canonized by John Paul II. Very briefly, she was Jewish. She lost her faith. She then became converted to Christianity and became a Carmelite with her sister. She was in Germany, moved to Netherlands, was caught by the Nazis and incarcerated and died a few days later in Auschwitz as a martyr. So I'd just like to conclude with a few comments from Edith Stein and from John Paul II. First, with John Paul II, to summarize a lot of what I've said in trying to bring together these two aspects of the objective and the subjective, the laws, the morality, the fundamental principles of our medical practice, and the existential problem that we must all face. John Paul II said, medicine is always at the service of life. Even when medical treatment is unable to defeat a serious pathology, all its possibilities are directed to the alleviation of suffering. Work enthusiastically to help the patient in every situation means being aware of the inalienable dignity of every human being, even in the extreme conditions of terminal illness. Christians recognize this devotion as a fundamental dimension of their vocation. Indeed, in carrying out this task, they know that they are caring for Christ himself. It is therefore through Christ and in Christ that light is thrown on the riddle of suffering and death, which apart from his gospel overwhelms us, as recalled in Gaudium et Spes. He canonized Edith Stein, I think in 1998. And in his homily, he quotes from Edith Stein. A patron of Europe. So this is John Paul II quoting Edith Stein. Our love of neighbor is the measure of our love of God. For Christians, and not only for them, no one is a stranger. The love of Christ knows no borders. And this again is Edith Stein. No spiritual work comes into the world without great suffering. It always challenges the whole person. So when we are faced with a dying person, we must also reflect on that great existential problem that will face us all. And we, like them, must face up to the reality. We must go beyond self-determination, self-actualization, to self-transcendence. Go beyond self to what we believe. The love of God and the love of neighbor. Thank you.